Hello, welcome everybody. Welcome to our S.P.A.R discussion. Tonight we're going to be discussing direct versus indirect decompression for the treatment of degenerative spondylolisthesis. And tonight we have three very distinguished guests. First is Dr. Raymond Gardocki, who is an assistant professor at the University of Tennessee Health Sciences Center, the Campbell Clinic Orthopedics. Welcome, Dr. Gardocki.
Hey, Paul.
Hey. Next, we have Dr. Juan Uribe, who's the chief of the Division of Spinal Disorders. He's the Volker Sonntag Chair of Spine Research and vice chairman of neurosurgery at the Barrow Neurologic Institute. Welcome, Dr. Uribe.
Thank you.
And last but not least, we have Dr. Peter Derman, who's a minimally invasive and endoscopic spine surgeon out of the Texas Back Institute. Welcome.
Thanks for having me.
And I'm Dr. Paul Houle. I'm a neurosurgeon for Cape Cod Healthcare Neurosurgery, and I'll be your host this evening. So, just a couple of things. Please, this is open to questions, so please leave comments. Prior to the discussion, we had people vote on the case that we're about to present, and I'm going to show you what the results are, and after the end, we're going to have you vote again to see if anyone changes your mind on how this case should be treated. So without any further ado, let's get right into the presentation of the case. This is a case of clinical equipoise, direct versus indirect decompression for the treatment of degenerative spondylolisthesis. So this is a 59-year-old woman who's had several years of back pain and bilateral leg pain, right greater than left, in an L5 distribution, and she had mechanical back pain. She now had progressive right lower extremity neurologic deficit with weakness in dorsiflexion and some numbness in the right L5 distribution, but her left lower extremity had normal strength and sensation. These are her preoperative x-rays. And one point here, I know that this is Dr. Gardocki's case, and I know he prefers to do the flexion and extension x-rays in the seated position to isolate the hips and to eliminate flexion at the hip. So you really isolate the spine. That was a nice little pearl he gave in one of our previous lectures. And you can see that there's quite a bit of movement between flexion and extension at the L4-5 level. Here is the patient's MRI, and you see demonstrated at the L4-5 level significant facet arthropathy, as well as spinal stenosis and the degenerative listhesis. And so we presented this case to the people who registered, and the pre-debate poll results is that 79% of the respondents would treat this posteriorly, 17% would treat this laterally, and 4% would treat this anteriorly. So just to get the ball rolling, pretty interesting way that people are going to have voted, and I think that you guys are all going to do your best to say why Dr. Gardocki should not, how he should do this case. So let's get right into the presentations with Dr. Gardocki. Go ahead, Dr. Gardocki.
I'm already at a disadvantage here because we're looking at 79% already wanting to go posterior, so I don't see how I can improve much on that. It's probably going to be ideologues left. We're going to get started with the slides here. There's just a little delay, Paul, so.
Okay. Can you see this? You're on your first slide. I am biased.
Yeah. So hold on just a sec. It might be better here for me to do this in a different way.
So to keep things going, it says that you're a pessimist and that you like to choose procedures that minimize the potential of complications. And your basic premise is that no matter what you do, if everything goes well, your patient's going to be happy no matter what surgical approach is performed. And you tend to choose procedures that allow things to go easy when things go poorly. And
yeah,
so
I got you now.
All right.
So So basically, I'm a pessimist. I'm a downside guy. I don't go on the upside because if everything's good, everybody's going to be happy. I believe that minimally invasive and endoscopic approaches are superior to open. I think literature bears that out. Long-term results of most of these procedures are similar and more related to the underlying pathology. And your biggest impact as a surgeon comes in minimizing the acute morbidity and recovery as long as the fundamental goals of the operation are achieved. So that kind of brings you to the fundamental question of, well, what are the fundamental goals, objectives of surgical treatment of dynamic degenerative spondylolisthesis? Well, number one, tried and true, is decompression of neural elements. So the best way to relieve claudication and neurologic deficits is decompress the neural elements. This raises the basic question of whether direct or indirect decompression is superior, which is what we're debating here tonight. And there are questions in the literature as to whether or not indirect decompression can alleviate bony stenosis or significant lateral recess stenosis. But it's not an issue with direct decompression. That's fundamentally the way to decompress these things. The other issue here is stabilization of the unstable motion segment. And I think we all agree that interbody fusions and minimally invasive techniques are the way to go. Really, the question is what approach is the best way to access the interbody space, and which approaches are truly minimally invasive, because everybody calls himself a minimally invasive surgeon, and then they do the bait and switch. So I'm going to give you the top 10 reasons why direct decompression and interbody fusion from a posterior approach is superior to anterior lateral interbody fusions, relying solely upon indirect decompression for the treatment of degenerative spondylolisthesis with neurologic deficit, claudication, and upper back pain. So I used David Letterman's top 10 list. Dr. Derman's probably not old enough to remember this, but I needed to keep it down to only 10 points because we have a limited time format. So this helped constrain me.
Oh, and I thought it was because you guys are orthopedic surgeons.
That's as high as I can count, right?
Yeah.
So I forgot to take my shoes off. So number 10, it's familiar anatomy. Posterior approach has a uniformity of technique. We already perform laminectomies and discectomies in the prone position from a posterior approach. The surgeon and staff are familiar with the instruments, room setup, and the issues you can have with prone positioning. So we're very good at this. There's a repetition of technique that makes you better, and the results with the posterior approach are reproducible in many hands. So, reproducibility is a very important issue. And even the Society of Lateral Access Surgeons admit that lateral approaches are technically demanding. So number 9, we can address any lumbar level. ALIF is great at 5-1 most of the time and can be challenging at 4-5 and higher depending upon the vascular anatomy. Lateral approaches generally allow easy access above L4, but L4-5 leads to the highest complication rates, and 5-1 requires a different approach. And the most common levels for degenerative spondylolisthesis are 4-5 and 5-1. So why would you pick the highest complication that you can only access half the spots? Posterior direct decompression and transforaminal interbody can be achieved at any lumbar level, even using minimally invasive techniques. So that's why I like that one. Number 8, revisions can be done safely posteriorly. So posterior approach doesn't prevent re-exposure from the same approach like the lateral retroperitoneal approach does. Revising a previous posterior procedure from a posterior approach is not generally a life-threatening procedure as it is for anterior approaches. Or you can annihilate the facets if you need to decompress both the central canal and the foramens. Bilateral facetectomies can still be done in a minimally invasive fashion, though the same surgical cord through the same surgical corridor as a screw placement. So Anterior lateral approaches would require you to come back and do a posterior approach and instrument and have a separate surgical approach and separate surgical positioning in most cases. And, that's just multiple surgeries on the same patient. That's not really minimally invasive. Reason number 5, a one operation approach to address pathology without the need for multiple surgical corridors. So that was a nice segue. I can achieve direct decompression and fusion through the same surgical corridor as pedicle screw placement. So why would I want to be in the retroperitoneum or dissect through the psoas? The psoas is something you go around, not through. These are patients, not pancakes. Flipping them is unnecessary. So Dr. Uribe and Dr. Derman are probably going to say, well, we can do this standalone. We don't need to do a flip and a turn and a separate thing. But the issue is that standalone laterals and obliques have very high subsidence rates and a high rate of subsequent need for decompressions without the posterior instrumentation. So you really give away one of the advantages they have, which is a lower subsidence rate if you do it standalone. Number 4, it's truly minimally invasive surgery. Again, if you're doing the same surgery through the same corridor and not disrupting other tissue planes and retracting on large vessels, it's less invasive. The decompression alone is an option from posterior. You can't decompress alone from lateral or anterior. So the least invasive thing is no fusion. And if you have somebody that is not moving, has a fixed position, you can get away with decompressing them in some cases. So Dr. Hartle's published a lot of good articles about doing decompressions alone minimally invasively on spondylolisthesis and having a very low need for further surgery, somewhere around 30% range. And you can save a majority of the patients a fusion in some cases just by going posterior. The surgical approach from the front and the back or side from the back violates the basic tenets of minimizing collateral damage, essential to minimally invasive surgery. So it's multiple minimally invasive surgeries is not a minimally invasive surgery. It's multiple surgeries. Standalones, which again would be the way to do this through a single approach, lateral or anterior. Again, high subsidence rates, need for subsequent decompressions without post-transplantation. If you do a posterior decompression and interbody and you get subsidence, you've already decompressed it. So if you do the anterior or the lateral and you get subsidence, hoping and dreaming for indirect decompression, and you have to take them back, you just did 2 surgeries for one pathology, whereas you could just address it from the front end. Reason number 3, potential to perform outpatient and awake surgery without general anesthesia. Now, my friend Georgios Bakalautis in Italy does do some laterals awake, but again, that's not necessarily reproducible. We've awake outpatient surgery is sorted out with the posterior approach. You get decreased delirium in the elderly, less narcotic usage post-op, faster discharge, less cost. And fortunately, there's not even a need for COVID testing with intubation. If they're afebrile and they don't have any contacts, you don't have to go through the nasal swab and the wait to 3 days and all that rigmarole. Reason number 2, it just requires less. You don't necessarily need to have neural monitoring like it is with a lateral position. You don't need a directional probe and motor evoked potentials. There's no need to coordinate schedules with an access surgeon. Like I can just schedule my case. I don't have to worry about, is the general surgeon around? Is the vascular surgeon around? Is my approach guy around? And there's no need for general surgery, urology, and vascular surgery to be near the operating room on the same day. So if you do have a complication, and there are people that are going to say, well, I don't get complications. Well, they're either lying or they don't operate. Those are the 2 possibilities. So if you do a lot of cases, eventually you're going to have a problem. And if general surgery is not in the building, or urology is not in the building, or vascular surgery is not in the building, you have a significant risk for catastrophic complication. If you're operating in a major center like Barrow and Texas Back, those guys may be floating around all day long. But if you're in a community hospital, like the hospital we're operating on, we didn't even have urology coverage. So that's a major issue. And then the number 1 reason to do a posterior direct decompression and interbody is it minimizes the risk of significant complications, especially those which are catastrophic and need to be dealt with by another specialty. So again, I'm a pessimist. I like to manage my downside risk. If I have a complication, I want to be able to deal with it. I don't want to have to call somebody else or another specialty to come into the room and bail me out. So if you look at kind of complications that can happen and you divide it up into highest risk, moderate risk and lowest risk. Really, a major vascular injury, posterior approach is the lowest. Bowel injury, posterior approach is lowest. Ureter injury, posterior approach is the lowest. Retrograde ejaculation, posterior approach is really low. Sympathetic dysfunction, posterior approach is lowest. Novel thigh pain or sensory deficit, thigh pain, psoas hematoma, abdominal wall denervation or hernia. DVT, the only thing that really you have the highest risk for with a posterior approach is CSF leak, which then your risk is the same, probably even lower with the posterior approach. If you do a standalone anterior or lateral and you have to come back and decompress them later, because now all those neural tension, all the tissue's under neural tension, so and it's extra compressed and non-mobile. So really, I would prefer to have a CSF leak than a vascular injury because I can deal with that and I know how to deal with that. If I'm doing a minimally invasive approach, really the CSF leak is not a major issue. It's something that can be dealt with very easily. I can still do it as an outpatient with the patient awake. So therefore, a minimally invasive posterior interbody fusion, either TLIF or PLIF approach with direct decompression of the neural elements is the best surgical procedure to treat symptomatic degenerative spondylolisthesis with neurologic deficit, claudication, and mechanical backbone. I'd just like to point out that I didn't have to resort to ad hominem attacks because that is when you have a very weak argument and you attack the speaker. So I rest my case.
Well, it was perfect presentation there, Ray. You make a very strong argument. We happen to have lost Dr. Uribe. Let's see here.
I'm here. I just don't see you guys' presentations. I mean, I have to go into YouTube. I don't get it.
No. Okay, you're back. So we switched you. Dr. Uribe is in Dr. Durbin's spot, but that's okay.
But how can I, Paul?
Yes.
Sorry to bother you guys. How can I see the presentation?
So
I only see your face.
You should be seeing everything that I'm seeing.
No, I just see your face.
You see my face?
Yeah, I had to pull mine up on a separate screen
on
YouTube.
Paul, Peter, and Raymond, and that's it.
Yeah, it's not on our screen, Paul. It's you have to look at it.
Go to YouTube or something. I don't know.
Okay, no, here it's coming to you right now. There you go.
That's weird. No, I see Raymond's face only.
Well, let's go right into your presentation, Dr. Uribe. Do you see the? You should see the screen right now, and we'll.
Blue.
How about that?
No, did you guys see it, Peter or Raymond?
No, I pulled it up on my phone basically.
Yeah, can you open so I can share my screen, or it doesn't work?
Hold on, it says it's being output. So let me just try one more thing. I'm sorry for all the viewers out there. We're having some technical difficulties that I'm not quite sure why.
If you open and let me share my screen, I have it in my computer.
Okay. Just one moment. All right. So
amazing, Ray, amazing that you did it. Like I was like, how you did it?
I can't tell you all my secrets.
You can't tell you. We can't tell you yet because. All right.
Actually, I just looked at my talk on the monitor and hoped that Paul was advancing at the right spot.
I know. I was wondering why you weren't saying anything. So, so I made it so that you guys should see the whole screen. That's what you should be seeing. So
we just see the speaker.
I see Peter right now. You look good.
All right. Well.
And it's very interesting because it only say 4 participants. If you go to YouTube, there is 100 people.
Yeah, there's quite a bit. So. Yeah, it should be working. It says it's sending it out to you. Let's send it one more time. Virtual camera out. All right, well.
Juan, what if I do this?
Yeah, that's what I'm looking at. I'm putting it on YouTube right now, but the problem is
It's
You can look at
it's
my
delayed.
screen.
It's delayed.
Listen, Paul, can you share? Let me share my screen with you, or that doesn't work for you?
It's not going to work for me. Hold on a second.
Well, so, hey Juan, what you can do is pull up your talk just on your computer and advance the slides, and Paul will keep up with you. That's what I did. The delay between YouTube and the call we have is like 30 seconds, so that's why I couldn't figure out what to do at the beginning.
It's gonna be tough because I have many clicks and clicks and clicks.
Yeah, no, I saw yours. So,
Yeah.
let me just do this.
If you can let me share my screen, maybe it works.
Yeah, I'm going to share your screen. Hold on a second. Oh, unfortunately, this isn't working. So,
Yeah. Okay.
do you have your on your computer your presentation?
Yeah, I haven't.
And you just give your presentation, and I'll click through the slides.
Okay.
And you just tell me when.
Okay, 1 second. Let me see if I can find it. Okay.
So Dr. Uribe is going to tell us why Dr. Gardaki is full of it. I'm going to enjoy
Okay.
this.
Okay, so we're gonna try now, Paul.
Yes, go ahead.
Okay, so exactly what you say, Paul, is what happened in the real world. 80% of the surgeries that happens, at least in America, for an spondylolisthesis is a TLIF surgery. It's amazing, yeah. And then 20% is between, ALIF and laterals. Ray and me, what we're talking about, basically in indirect decompression, and that has been our goal. Trying to convince the world that actually the indirect decompression is an amazing surgery with a lot of advantages, and this is going to be one of my tries. I'm not going to stop until we see how the world convert, because it's an amazing option. I'm going to show you actually a similar case that the one that Paul presented that actually can be done very good with lateral. So let's go with the next one. So basically we are, I'm here against ALIF and the TLIF. But first I want to talk a little bit about the history of interbody fusion, and then you guys understand where are we coming from. So because they look similar, the three options, but then go to the next one, Paul. So if you're looking here, to me, we start from a little bit of history. TLIF, to me, we make an analogy with the music. TLIF is basically the cassettes. And then you go next. ALIF, to me, is like a nice vintage. I still have a piece of my heart as a piece for the ALIF, because I think it's the same principle in direct decompression. So you don't need to get and violate posterior elements. And then the next one is the TLIF, which is like an antiquated way to do the things. It's cool based on the 90s. It's kind of a little updated. But then this is basically what happened with the lateral axis. This is what we have. This is the state of the art. This is the way that I think it should go. So, and then you go next. And then when we look at the stability and the fusion platform of these systems, so actually the lateral, as you see here, it's on a very generous implant that goes from one endplate to the other one. The TLIF is a little cage that had to be negotiated through the Cambis triangle that is like a 1.5 centimeter. And then you're trying to make something out of that with a hard, way to make a really good discectomy and Endplate preparation. And then obviously the ALIF is like the little brother of the lateral. Using here, the cage is big, but not big enough that can go one Endplate to the other one. So the environment for a fusion, I would say, is way more generous that you created with the lateral than anything else. Go to the next one. So the question is why we do lateral, and I'm gonna tell you why. It's actually meet the 4 criterion of a really good fusion procedure. One, go next, decompress, align. So you keep pushing with me the clicks, Paul, fuse, and provide a really good anterior column support. So hopefully we are on the same image, Paul. So as you see here, the procedure meets all the 4 requirements: decompress, align, fuse, and provide anterior column support. So it's just showing a little bit of that diagrams, and one of our cases using here how we work the indirect decompression. On the left side of the images, you see preoperative CT and MRIs and the diagram in the middle. And then on the right, you see how by regaining this height and pulling back the vertebra that has the anterior listhesis, actually you get a really good canal decompression as we see on the lower picture on the right, without the need to do any laminectomies, foraminotomies so far. And then, so go to the next one. So then I'm gonna show you a real example. It's pretty much the same one that Paul was showing. So go to the next one, 42-year-old woman, spondylolisthesis, as you see here, flexion extension films, unstable. Go to the next one. This is the MRI pre-op. As you see, classic spondylolisthesis, bilateral foraminal stenosis, a little bit of central compression. This is the CT. You go to the next one. This is the CT that showed part defect, and then the grade 1-2 spondylolisthesis on 4-5. Go to the next one. In this case, we're doing it now in order to have time savings. And this is something that now we're competing head-to-head with the TLIF for the critics that used to say that when you do a lateral, then you have to flip the patient prone. Actually, we can put the screws on the lateral position, but if you really want to put the screws on the prone position, we do it like a prone lateral, and at the same time, we put the screws on the position that you need without the need of repositioning. Go to the next one. So just go to the next one. Let's keep the video. And then as you see here, a very clean procedure. You dilate to the abdominal muscles. You go to the next one, and then you find the way to go through the psoas. You negotiate the lumbar plexus. Then you put your cages, just keep going. In this case, as you see here, this is a 22 millimeter by 55 millimeter length with a good lordosis cage. It goes from one diaphysis to the other one. And as you see here, start doing partial reduction of the spondylolisthesis, as you see on the left image, and then full reduction once you put the percutaneous screws. And this is just next showing a images pre and post, full anatomical reduction, and good preservation of the sagittal balance. So the question is, I mean, what is wrong with this surgery? You know, when you can put the biggest implant that you can put, you reduce the anatomic, and the patients do great, and you don't need to touch the posterior tension bands when you don't have to, you know. This is next, you see the MRI before and after. I mean, it's a perfect indirect decompression, good restoration of the disc height, keeping the lordosis, and having an amazing setup for a fusion. So I would say, I mean, it's hard to find a procedure that gives you better than this. Go next. You see the CT pre and post. You see how good everything looks, a good alignment, good placement of the cage, as you see through and through. Go next. So the question is, now you're gonna say, well, there is no evidence. This is because you're very good at this and you're the only one who does it. But the real truth is that there is more than 2,000 surgeons every day doing lateral surgery in patients all over the place with a really good outcomes. Go to the next. So this is our own publications. As you see here, 2013, we published like a good series of grade 1 and 4-5 spondylolisthesis that is actually the more criticized level on lateral with a really good results. Go to the next one. So this is just showing a little bit of details of the patient population. Next one, with a really good clinical results. Go to the next one. And as you see here, definitely patients do very good. There is no reason to go and do a direct decompression and put small cages for that. This is our more recent publication, as we just try to pull out only our grade 2 spondylolisthesis treated with indirect decompression and lateral, also with a really good result. This is something that the audience can look on detail in PubMed. You find everywhere this more details about how this technique works on grade 2 spondylolisthesis. Go to the next one. This is just a little bit example of another one. Go to the next one. This is basically what all the literature, I just make a summary for you guys, basically what is the results of the lateral surgery for spondylolisthesis using here, great patient satisfaction, really good fusion rates, or time you're not sacrificing. And this data is even when you were changing positions. Now that we're doing single position surgery, lateral or prone, actually work very good. Go to the next one. So now to finish, I'm gonna show you what I think the disadvantages of the ALIF and the TLIFs. So first on the ALIF, obviously still you have chances of lumbar plexus injuries. You think that the lateral can do it. You do an OLIF, whatever you name it, always you have chances to get autonomic injuries. You have to deal with the sympathetic and parasympathetic plexus. Always the bases are waiting for you to make an injury. You can injure the ureter, you can have ileus, pseudo hernias, regal hernias, and that's the old things. And then over the top of everything, you need an access surgeon to do it for you. So in few places in the world, actually the surgeon does the entire ALIF access for you. And when you start mixing not only 5-1, but 3-4, 2-3, it becomes a big deal, you know? So then let's move on the TLIF. The problem with the TLIF to me is obviously the very narrow access. You're working through 1.5 centimeter. The Camping triangle is restricted. The working channel that you have to take the paraspinal soft tissue down. For example, what Ray was proposing, like do a standalone reduction only, it doesn't exist, a TLIF standalone. Every time you do a TLIF, you have to put screws, want it or not, you know? And then obviously, if you're not a good TLIFer, you got a good potential for loss of lordosis. So go to the next one. So in summary, you see here, this is just a specimen showing the amount of, go next and next, the amount of discectomies that you can do when you do a TLIF on the left versus a lateral. You see how nice you go through, and generous you do a discectomy. Go to the next one. So to me, in conclusion, this is what I have to say about the TLIF, which is very hard for me because 80% of the people are doing this one out there. And I don't judge them because, I mean, unfortunately, the generation of surgeons that are the big workforce in the world right now, they were trained doing TLIFs. Most of us, we were not trained doing lateral. But you will see next generation of surgeons in 20 years, that 80-20 that we have at the beginning, Paul, it will be the other way. 80% lateral or ALIF, 20% TLIF. Why? Because to me, the TLIF, that significant posterior element disruption, it has a useless indirect decompression. It has a potential for CSF leaks, as you know, the complications. It can be kyphotic procedure, and the smaller preparation of the Endplate. So in other words, you go to the next one, actually a TLIF sucks big time. And you know, see the picture. So that's pretty much for me. Thanks very much. And hopefully Peter come with something good. Peter, you have all the audience with you, but to be honest, you will see it in 20 years, you will be one more of the ALIF of lateral guys. Thank you.
So let me ask you a question. Is there any case where you might consider doing a TLIF as opposed to a lateral procedure?
Yeah, I mean, there's some cases, for example, patients with recurrent disc herniation, you know, like the second or the third time you have a disc herniation, that you have a severe radiculopathy and you're not getting better and they have minimal back pain. To me, that patient may be a TLIF candidate. After that, to be honest, very few of them. You know, obviously patients with significant, like a short pedicle syndrome, neurogenic claudication, bad stenosis. But in those patients, a lot of times I just do lateral and then I do laminectomy on the back and then I get the good fusion. But at the end, you know, obviously it's a dealer's choice, but I think is it's a generational change. You know, when I see my residents and my fellows, when they finish, they're doing less TLIFs and more lateral and ALIFs, and that's the little change on the future. I mean, I'm sure that Peter is gonna choose hard TLIF, but I'm sure that he's gonna see it on his own practice. His people that are turning a little bit.
And how do you address the issue of L5S1?
Yeah, 5S1 is an ALIF. My friend Ray, we close together on this one. Yeah, 5-1 is an ALIF to me. So once in a while I do TLIF. Don't take me wrong, you know, it's because we're debating in here. But to me, 5-1 is an ALIF. I like it. It's a really good, generous foundation fusion area. You can really get very comprehensive. The fusion rates are very good. 5-1, you know, is the most difficult level to fuse on the lumbar spine. But again, you know, it's a generational change. You know, it's the fight that we have. You know, I know that you're endoscopy, Paul, correct?
Yes.
Yeah, I know endoscopy is a different animal because you're doing a very little minimalistic way, which is in my side of my heart also. And I think, you know, endoscopic interbody fusion, that's a different animal than the mini open TLIF to me. You know, it may have more attractive because it's the true minimalist invasive expression of a fusion.
So that's actually minimally invasive, is what you're saying.
Exactly.
Excellent point. So now we're going to move on to Dr. Derman, and he's going to make his case for ALIF for spondylolisthesis.
Yes. So Juan, you and I agree that TLIF sucks. I think we can take that off the table.
I know that you invited us.
I do laterals. But I'm going to talk about ALIF today, and I think ALIF is a great tool. So if you could just go to my next slide, which I think is the most important slide. And I think I can probably just end my presentation here because I can't remember the last person who won the Masters after their TLIF. Just doesn't happen. And when Tiger Woods, I don't know where he had his surgeries, you know, I don't know really anything about it. But he doesn't have a lateral. He has an ALIF. And so I like to counsel my patients now after an ALIF that there is a 100% chance that you will win the Masters after this surgery. It's just a matter of time. So
well, I'm going out and having surgery tomorrow.
So next slide, please. So just to show some data, if that wasn't enough for you guys, basically, you know, I'm a minimally invasive surgeon. I do a lot of degen type pathology. I like to do it well. And even though I don't do a ton of big deformity, I feel like if you aren't treating a deformity, you're creating it. So on any fusion case, even a single level fusion, I'm measuring, you know, spinal pelvic parameters and trying to optimize things for my patient because I don't want to create a deformity. I don't want to have a problem down the line. And there's very strong data to show that, you know, having a positive SVA, having flat back, is one of the most debilitating things that you can have. I mean, ODI goes up as your SVA goes up, et cetera. So, you know, even for a single level fusion, I'm trying to optimize my lordosis, et cetera. Next slide. So there's some strong data comparing XLIF, ALIF, TLIF with respect to these parameters. This is one of the studies that I pulled. It was a retrospective review of 220 patients with 309 levels. It's a little bit on the older side, so they use 6-degree ALIF and lateral cages and a non-lordotic TLIF cage. Not sure how generalizable this is. I routinely use 20 or more degrees in my ALIFs, but nonetheless, this is the data that exists. And they looked at post-operative parameters. Next slide, please. And this is what you see, that with respect to lordosis, there's a trend that goes down. ALIF is the best, then lateral, then TLIF. And this is the case across the board. I mean, TLIF, if you get any lordosis, you're lucky. And it's largely considered a kyphosing procedure in many respects. So if you look at the table, the table on the right there, you can see that there was a statistically significant superiority to ALIF over lateral for lordosis. over TLIF for lordosis and disc height. So clearly superior with respect to these radiographic measures at long-term follow-up. Next slide. Here's a meta-analysis looking at all the literature comparing these things, and again, a similar kind of theme. ALIF has superior radiographical outcome, achieving better postoperative disc height and postoperative segmental lordosis. So, I don't want a fusion, but if I need a fusion, I want as much lordosis as I can there. And an ALIF is the most effective way of providing that. So some pictures can help. So next slide. So this is a guy I did like 2 weeks ago. He had a high-grade lytic spondy. And, I think, Ray, I know you're a fantastic surgeon, but, maybe you could make it look like this after a TLIF, but it'd be really hard. And an ALIF makes it pretty easy, and you can get a nice big cage in there. And the other thing I like about it is every time I see the patient back and their x-rays loading up on my screen, I don't have like this anxiety like, oh my gosh, is it subsided? Is my cage moved? No, every post-op x-ray looks exactly like I left it. And that's not because I'm some spectacular surgeon, that's because you got a nice big cage in there. Can this be done minimally invasively? Absolutely. So next slide. These are the postoperative dressings of that high-grade spondy that I just showed, showing that you can really do this without not only just making small incisions, but without damaging the soft tissues. You're from the anterior approach, you're going between the abs, and so you're not cutting anything. And as a result, patients get up and they get out of the hospital. Next slide. I don't have a long-term follow-up on that one because I just did him, but this is a guy in his 70s that I saw recently. He's about a year out from surgery. I put a 20-degree cage in at 5'1", and I put I think that was an 8 or a 10 at 4'5", because that's what he needed. I could have gone as much as I wanted to, and you can see this is an older gentleman, and he hasn't subsided in the least. He's got exactly where I left him on the day of surgery, which is what I like. It's kind of a set it and forget it. Next slide. So I'm going to go through first TLIF, and then we'll talk about lateral. I want to interrupt you for a second. If you go back to that case there's a pretty significant disc space collapse at L5S1, and it's probably on the order of 4 to 5 millimeters in disc space height there, and you've jacked them up to probably about 14 to 16 millimeters. Do you ever worry about traction of the exiting L5 nerve root when you do that? Absolutely. So I'm very careful. When I call for my cages in the operating room, I have them call by the posterior height, not the anterior height. I don't really care what the anterior height is, right? What we care about is the footprint, the posterior height, and the lordosis. And the anterior height is just a function of those things. And so what I do is I measure the preoperative posterior height, and then I make sure that I don't jack it up. Here I kind of jacked it up. But I try not to increase it more than, say, 3 millimeters from what it was before. And so some of these patients do get postoperative stretch symptoms. This patient in particular did get postoperative stretch symptoms, but they resolved completely. And so, I talked to him last week. He had just played 18 holes of golf 3 days in a row and had hiked a mountain. So, he's pretty happy with his surgery. But it's a good question, and it's something I am cognizant of.
Did he play at the Masters? At Augusta?
Not yet. He's practicing.
All right, I'm on your MIS TLIF slide with the Ferrari.
But by the way, I do always look at those Endplate spurs too, because they can get Endplate osteophytes off of, say, L5 that can tether the nerve. And when you jack them up, you can really pull on the nerve. So, I do a lot of endoscopic surgery too. I just signed up a lady recently for an ALIF with bilateral endoscopic foraminotomies because I want to take down those tethers there. So anyway, the MIS TLIF, it's like the Ferrari of MIS surgery, right? Like I trained at a MIS heavy program, and the sexiest surgery you could do was an MIS TLIF through a little tube, and it seemed really cool. And then you start to follow these patients and you start thinking about it. Next slide, and it's not a Ferrari. What it is a Jenga thing, all stacked up on this one little Lego. And so biomechanically, it doesn't make any sense to me at all. What you want is the biggest foundation you can for fusion and for stability to improve fusion. So this is what an MIS TLIF is for me, and why it's kind of my surgery of last resort. Next slide. Texas Back Institute, obviously, we are very anterior heavy in general. I'm sure you can see that in my biases here. And this is something that we say frequently is that TLIF is more of a disease than a surgery. And that's because we revise a lot of TLIFs. Pseudo is a real thing. And there's flat back, and there's all these issues associated with those TLIFs. Next slide. I wrote up recently with Kern Singh looking at revision strategies for lumbar pseudoarthrosis. And as part of this, I did a literature review. And the literature shows that there's not strong evidence for any of these fusion techniques over the other ones, which is probably because our measurements are not sensitive enough. I don't know. But what I can tell you is I've had a difficult time finding any reports of how to revise or anyone revising ALIFs or laterals for that matter. There's just not that many pseudos, but there's tons written about revising TLIF pseudos because they happen a lot. And yes, I patted myself on the back. I cited my own paper there. Juan didn't seem to have a problem doing it, so it's okay. Next slide. This slide says it all. If it wasn't the tiger slide, like this slide. So this is a case I did not long ago. It was another of the pseudo TLIFs that I took care of. I went to the front, which I think is the best way to do it. Pulled it out. You could have pulled it out with your fingers because it was so wobbly. And the TLIF cage fit inside the graft window of my ALIF cage, which, I mean, I think a picture just says 1,000 words. What I want is an ALIF supporting me, not a little tiny Lego. Juan spoke a little bit about disc prep. This is a paper. It's a little bit on the older side now, but I think it's valuable. Came out of Rothman, showing how much disc prep you can do from a TLIF approach. And this is like ideal scenario, right? This is a cadaver. You're not worried about time or anything else. And how much disc prep could you do? And it's limited, especially in that, contralateral posterior quadrant. You're really not doing that much. And ALIF, you can get every strand of disc out of there to completely mobilize that level and encourage fusion. XLIF's probably somewhere in between. Next slide. Direct decompression is something that Ray referred to and one of the benefits of TLIF. I think what we're finding more and more is direct decompression is oftentimes not necessary. So this is a little sneak peek of some data that I'm presenting at NAS from Texas Back. So if you go to the next slide, I'm not sure which slide I'm actually up to, but it's the one that says indirect decompression.
Yeah, we're there.
ALIF works.
Yep.
And so this was a retrospective review of our data at Texas Back. I looked at the last 568 patients who underwent a single level ALIF with or without posterior instrumentation. No direct decompression in these cases. All of them had either claudication and or radiculopathy. And what we showed is that only 4% of them at any point had to return to the operating room for a direct decompression. So that is 4%, but that's 4% that didn't need to have the neural elements manipulated in any way and had an ALIF, which was a very effective way of taking care of their problem. I think that an interesting thing we'll be able to look at and predict better who those 4% are, and something that I'm looking into as well. So that's TLIF. That was easy, even though 80% of people, I guess, disagree. But certainly what I would not want a TLIF in myself if I could avoid it. Next slide is lateral and OLIF have limitations. We kind of touched upon these. Lateral lumbar plexus injury, psoas hematoma, and then crest and psoas anatomy can make it an impossible thing at times. And then OLIF, similar things, but also higher risk of vascular and visceral injury. Then the other thing is, again, lordosis. Now ACRs have been described, and lots of people do ACRs in their laterals, and I think that's a great tool to have. But it's kind of a pucker factor surgery, right? Nobody's like, I'm just going to do a quick ACR. Like, that's a big deal component of the surgery with high risk associated with it. Next slide, please. Now, in an ALIF, you are doing an ACR every single time. The ALIF is the original ACR. It's the OG of ACRs. And it's done in a very controlled and safe manner where you're looking at what you're doing, releasing that ALL, and allowing yourself full access to the disc and the ability to really mobilize things. Next slide, please. So just to sum up, I would like to thank everyone for having me here. It's a real honor to sit remotely alongside Dr. Gardaki and Dr. Uribe. Yes, I'm the young guy in the crowd here, but I think I have something to say. Next slide here. I'm just really apologetic that I had to do this to my two colleagues here. And then final slide, next slide. I think we can all say, you know, who the victor is here, and that's the ALIF.
Well, that was a wonderful presentation. So what I'd like to do now is, for the people that are watching, I'd like to, in your comments, now after hearing the presentations, how would you treat this patient? So in the comments section, just write whether you do TLIF, Lateral, or ALIF. And we'll go ahead and tally the results. But how do you, I think one of the things that I've seen are the injuries to the sympathetic chain, and having some of the RSD type symptoms, I think, is a real issue. What do you guys think about that?
So it's interesting. When you do a sympathectomy on somebody after an ALIF, they complain about the contralateral leg because that's the cold one, and they like the warm one generally. I'd like to say that one of the things I see a lot with anterior and lateral and oblique and all these anterior approaches is really see a lot of overstuffing of the disc space. So I think lordosis is great. That's not an issue. I agree with that completely. I think an ALIF at 5'1" is a fantastic procedure. I mean, I was taught to do fronts on Tuesday, backs on Thursday, and keep people in the hospital for 5 days. But when you overstuff the disc, you still get subsides, even with an ALIF, even with a lateral. So really, the posterior disc height is what determines whether you can get indirect decompression. And the more lordotic you make it, the more you decrease your chance of posterior indirect decompression as well. So you close the foramen. So you really need to overstuff it. That's also not physiologic. If you look at the sagittal alignment on the patients preoperatively, if they don't have a PI-LL mismatch or off SVA, how much lordosis do you need? I mean, do you need to get 20 degrees of lordosis in every single patient? And I don't think you do. There's plenty of studies that show increased segmental lordosis and no change in overall lumbar lordosis. In fact, when we looked at our own TLIFs and we presented this data at the Minimally Invasive Spine Society, we found that, actually it was NAS last year, we found that overall lumbar lordosis actually improves even if segmental lordosis doesn't improve fantastically. And that's, I think, a function of the dynamic stabilizer. So like one of the questions I'd ask Peter is, if you're going to do the foraminotomies at 5'1" and then do the ALIF, why not just do the interbody if you're an endoscopic surgeon? Because I know you can do it endoscopically. So
I want a big cage. I want a big cage. I want a big cage. If there was a giant expandable TLIF endoscopic cage, it would be wonderful. But and I'm not saying that will never be the case, but there's not right now. So that's why. And by the way, the reason I think, and I can't prove this yet, but I want to, is the reason I think that overall lordosis doesn't change, even though segmental does, is because we've all seen people that are fused flat and they hyperlordose above. And so I think that by restoring what's a more natural lordosis, while it doesn't necessarily change their overall lordosis outside of a deformity procedure, it probably, and I can't prove this, is protective against the other levels, doing that hyperlordosis, retrolisthesis, and then an add-on problem.
So you brought up an interesting question. You said you saw natural lordosis. So when you say natural lordosis, what is natural lordosis? You see this in politicians all the time. They throw away a term that's
well, it depends who you're talking about. It's obviously age adjusted. But if you look at, just say healthy people off the street, there's studies that show that 5'1" lordosis is 30 degrees and 4'5" is 16 degrees. Obviously, in a
in an older person, it's going to be less than that, and I try to dial that in appropriately. But it's definitely more than 3 degrees, which is what a lot of the studies show that you get from a TLIF.
So there's actually a question from the audience directed for Dr. Uribe and Dr. Durman. Do you guys ever do standalone ALIFs or standalone laterals? Do you always back things up with pedicle screws? And if you do, what sort of parameters are you looking at if you're going to do a standalone?
I always back up my laterals. I do a lot of laterals too, by the way. I always back up my laterals because of concern for subsidence. I try not to back up my ALIFs if I can avoid it. So unless they have, a mobile slip or a lytic spondy or a real deformity or poor bone stock, I'll do a standalone ALIF.
Dr. Uribe?
Oh, you're muted.
I do fair amount of standalones, but what you need to know is first, patient has to have a good bone. So you don't want to do in patients with osteopenia because you're relying on the indirect decompression. Second, patient cannot have an instability. So in other words, pars defect on a spondylolisthesis, not a good setup for a standalone. So it's a fraction of patients, but what we like a lot on the standalone lateral is that it's 100% an ambulatory procedure. These people go home, same day. It's a 35-minute surgery, a single level. And if you do it right, you don't oversize. If you treat the endplates correctly, you put the wide implant, patients do great.
Do you brace them?
Say that again?
Do you put them in a brace if you
Not
do a
necessarily.
standalone?
Just to remind them that they have surgery and their wives or their husband not to put them to do too much chores at home. Yeah. That's pretty much.
Another question pertaining to this case, there was an observation made that the iliac crest in this particular case is at the mid-body of L4, which might make the lateral approach a little bit difficult. How do you respond to that?
Yeah, so the biggest challenge, more than the iliac crest height, is actually the psoas a transitional psoas. In other words, is as Raymond mentioned at the beginning, when the psoas is like a Mickey Mouse ears, is at transitional level, and the challenge is that you are retracting not the lumbar, not the femoral nerve. You're dealing with the sciatic nerve, and also sometimes when it's a transitional level, the bifurcation of the vessels is already early, so you can have the vessels in your way. So that's the biggest challenge. Having a high iliac crest is not a problem. You go with angle instruments and you can do it. The challenge is that when it's too high iliac crest, it's calling to the surgeon to go and look into the retroperitoneal, make sure that the anatomy is not transitional around this level. That's the big deal.
So I have an observation. I have a role as in the medical staff and do a lot of credentialing. And one of the things that we're seeing is the lack of trained general surgeons, just strictly general surgeons. We see lots of laparoscopic surgeons. We see lots of surgeon subspecialties, but not a whole lot of general surgeons these days. Do you, with the way graduate medical education is going, with so many people subspecializing, do you see that the lack of general surgeons is going to hamper the ALIF approach and the use of a general surgeon as we go forward? And more importantly, if you do have to revise an anterior or even a lateral approach with scarring and everything, with the limited numbers of general surgeons out there coming out, what do you think the future is going to hold?
Peter, you can answer that one. You're the big ALIFer in here.
So, obviously with ALIF, you are, dependent on an access surgeon, right? Whether that's a vascular surgeon or a general surgeon. And clearly if there's fewer of those being trained, then that's going to be a problematic as a whole. Although what I will say is there's even motion to make that anterior access its own fellowship within general surgery. So, there is interest out there in doing these cases. Obviously, revision anterior approaches are not something you ever really want to do. Most of the time, if you need to revise something, say somebody for some reason has a pseudo with an ALIF, you can do a posterior lateral fusion on them. So, try to avoid going back to the front if at all possible, although it's not impossible to do so. In our practice, we're obviously blessed in the fact that we do a ton of anterior surgery, and so the place is crawling with access surgeons. Like, there's probably 2 or 3 in the hospital at any given time, and they're very good. And so, I don't want to take for granted the fact that makes it very easy for us to do anterior surgery. But they do revision approaches when it's necessary, and patients get through it. But obviously something you want to avoid.
Well, actually, that begs another question to Dr. Uribe. What do you do in the case where you have a pseudoarthrosis in a lateral procedure? What's your salvage operation?
Yeah, first, that word doesn't exist on the lateral word. No, I'm joking. No, I'm joking. No, usually you have 2 strategies. One is you go from the other side, that is a virgin retroperitoneum, which is easier. And then, to be honest, going from the same side is actually not that complicated. Usually retroperitoneum doesn't scar too much when you go lateral, because I think what makes difficult the revision of the ALIFs is the vessel mobilization more than anything else. It's not the retroperitoneal itself. So I think in lateral usually I go from the virgin side. If I don't have that option, I go from the same side. If you have to, sometimes we review, we're revising TDRs that has been placed from the front sometime, which the lateral becomes good and the retroperitoneum still is good. Otherwise, you have to be careful, obviously. You don't want your first case be a revision. And the other thing, the first question that you said, is to me is very interesting because there is a great opportunity for general surgeons to become, surgeons in general to become an access surgeons. I've seen a lot of vascular surgeons, for example, in our area, migrating, becoming just specifically access surgeons. There is a lot of demand. ALIF is growing no matter what. It's becoming more and more. For example, I was just asking yesterday, one of our access surgeons, he said that I'm doing 30 to 40 surgeries a month. I just basically cannot stop on every hospital in the city. I just book all the time, and my life is great because I just go do the approach, and then rarely we have a complication that we need to follow up the patients. So they have a really good lifestyle, and they make, I would say, good economical support.
Well, those are all excellent pearls. So we're getting short on time now. I want to kind of bring this home. Dr. Gardocki, why don't you go ahead and tell us what you did?
Well,
so here's the treatment slide.
I'm sorry, what was that?
I got the treatment slide up.
Okay. Well, so basically, I actually did a PLIF approach on this patient, not a straight TLIF, and it was done endoscopically. So, the things that we talked about of having expandable technology that gives you better footprint, being able to achieve lordosis, restoring height, and doing it all through the same corridor with a direct decompression. So this patient had L5 radiculopathy, I think it was on the right side. So that's the side she had the direct decompression. We just took a little more facet on that side, and we're able to place a cage that goes in small, expands big, has good endplate prep, good fixation. This is one of the advantages of the endoscopic approach, actually, is the interbody prep is fantastic. So anybody that does a TLIF or PLIF, or when you poor souls are forced to do that because of either Mickey Mouse ears, vasculature, crest, previous abdominal surgery, we'll go through the list, like there's 25 things that stop you from doing this. If you're forced to do a posterior approach, I would recommend you do the interbody or the TLIF, bring in an arthroscope and look in the disc, just see what it looks like. I agree that the disc prep from a traditional TLIF PLIF is not as good, but when you do it endoscopically, you see the end plate, you can literally peel the cartilage directly off the end plate, and you get much better disc prep and a much better disc fill. So here you can see that the spondylolisthesis is completely reduced from the posterior approach. That's also a major component of your SVA. So, we forget that a degenerative spondylolisthesis is translational. That has as much effect on your overall sagittal balance as does just the segmental lordosis. So if you check this patient's segmental lordosis, it's actually better. So this was done as an outpatient. She didn't even have general anesthesia, so no urinary retention, nausea. Was sent home roughly 2 hours after surgery. So as we go to bundled payments in the future, keeping someone in the hospital for 5 days for a simple one-level procedure where you got to flip them and have vascular guys around, I think is going to become less and less feasible. And doing these things and shifting into the outpatient
center is going to be a cost savings for society in general.
So Ray, just to clarify, so you did an interlaminar approach with a bilateral direct decompression and then a PLIF through the interlaminar approach? Is that what you did?
So just because I did a PLIF doesn't mean I can't rely on some indirect decompression. So that's, again, the flexibility of the posterior approach. I did a unilateral decompression because that's the side she had the neurologic deficit on. She simply had nerve pain on the other side, no neurologic deficit. So simply stopping the motion should take care of that and restoring disc height. So I actually did the decompression on the same side, was really aggressive with my facet resection and made the decompression endoscopically easier because I didn't have to worry about preserving the pars. I didn't intentionally go across the pars. There was a slight sliver of lateral facet left, but made a bunch of space, retracted the traversing root, maybe a millimeter or two, and I was able to fit a flare hawk cage in there that went in at 7x7 and expanded up to 11x30. So a really pretty nice footprint. We got it all the way anterior, so it sits on the anterior apophyseal ring. And, there's some, a study that's going to be published probably next month for the CE mark for flare hawk that talks about potentially having zero subsidence and some restoration of lordosis. So, I think we can solve this problem. We know what the issues are. Don't overstuff, get good endplate prep, get good endplate conformity and a good enough footprint for that patient. That footprint's different for everybody. An osteoporotic 70-year-old is not the same as a healthy 50-year-old. So sometimes the Lego works, but if the Lego were bigger, it's going to be better. And that's what we're working on. So even when we talk about things like anterior column release, so actually in the lab on a cadaver, I've been able to do an anterior release from a posterior approach through the endoscope, which is, I think, could be a game changer.
Very cool. Looks good.
Yeah. So actually, there's a really wonderful question by Dr. Blumberg, Cal Blumberg. He says, none of the cases shown have significant anatomical stenosis. Is there some degree of stenosis severity that precludes an indirect decompression?
Yes.
Yes. The studies so far show that if a patient has rest pain, that's likely not a great candidate for an indirect decompression. If they have a lot of bony overgrowth of their facets causing bony lateral recess stenosis, that too is probably not a great candidate for indirect decompression. And then for me still, if they have like critical, complete central stenosis, I'll still do a direct decompression as well. Dr. Uribe, what do you think? Oh, you're muted again.
I will go the other way. To me, the best predictive factors of indirect decompressions are, one is loss of disc height. So you have to have loss of disc height to really try to do indirect decompression. Second, you have, patients with instability, pars defect, spondylolisthesis, great candidate for indirect decompression. Third, vacuum phenomenon. Every time you see air on the disc space, great candidate for indirect decompression. So that's basically the main drivers of the indirect decompression. Then which one is absolutely a no is obviously patient with a short pedicle syndrome, like a true congenital stenosis, because there is no room to do anything there. and second, patients with locked facets, like almost fused facets posterior. Also, there is now. After that, everything worked very good. We just, I wish this talk was a little bit more like a 2-3 months ahead, because we just barely get approved for our experience. When do we perform reoperations after indirect decompression? And in my series, 200 and something patients, since I'm moving here to the BNI, is 4%. So in other words, is 4% of the patients that I do indirect decompression, they end up having direct decompression. Which is more interesting is that out of that 4%, 50% of them, they don't get better even with the direct decompression. So mean patients that no matter what you do, they will never get better. So it's interesting, it's hard to get into the indirect decompression world, because it's a new discipline. All of us that we in here, we will train as a direct decompression. You don't leave the OR until you see the Christmas tree, each root coming out, and after each Kerrison goes to the foramen. But, I can tell, I talk for Peter and his mentors, like Geyer and Seblik, all the TBA surgeon that been through the years trying to show that indirect decompression actually works, leading the ALIF approach, in general anterior column surgery.
Yeah, but again, you got to keep in mind, Juan, you're one of the most prominent lateral surgeons on the planet, and you do more of these than most people. So, even in the hands of very experienced surgeons, the rates of thigh pain, psoas weakness, they're quite high. The rates of actually denervation of the abdominal wall and hernia there is probably higher than we realize. Because when I did some laterals, I had patients say, "Oh yeah, I got this thing that doesn't work here. I got this flap, but it's fine. It doesn't bother me." And set me aback. I never want to have somebody have a new neurologic deficit, and no matter what you do, you're going to have that if you're dissecting through the psoas.
That's a really good point, Raymond. No, it's a great point, Ray. The thing is that I always say that, especially when, we deal with residents and fellows, is the lateral access is a procedure that is more technically demanding than regular TLIF. TLIF, you can move the roots on and off, you can take 2, 3, 4 hours and nothing happened, So the lateral is very demanding in terms of you need to have a very standardized procedure. Your retraction of the lumbar plexus has a time limit. It's a lot of things that you have to get through it. And if you don't do it, as you say, the outcomes are not good enough. And that's what, I always compare, don't take me wrong, but I like cars a lot, like the TLIFs is like a Toyota or a Hyundai, they're very good moving you from point A to B. The lateral is the kind of the McLaren, the Ferrari, that if you know how to drive it, you do great. But if you don't know the first curve, you kill yourself. But at the end, don't take me wrong, it's a dealer choice. You do what you think is the best for your patients. We want to make sure that the audience is not gonna get biased for now. Because we here taking very dogmatic roles as Paul gave it to us. But at the end, is what you think is the safer for your patient. This is what you do.
So it's interesting too that the lateral approach shares some of the same issues as the posterior approach does, in that you're not going through a true anatomic plane like you are with an ALIF. You're dissecting through muscle tissue dynamic stabilizer. So, the benefit you get by using, say, a cage that expands both laterally and into lordosis is you get better footprint, you get less retraction. Those same benefits can be applied to a lateral approach. That's one of the issues is some of these fixed cages are big enough because that the front to back length of the cage has a very high correlation with the amount of subsidence you get even with a lateral approach. So you need at least a 22 or bigger cage. You go to a smaller one, you get less nerve symptoms, but you get more subsidence and you kind of lose the benefit of the lateral. So when you go to a bigger cage, you get more retraction of the nerve root and more dissection of the psoas. So imagine if you could insert a cage through a lateral approach through a tiny little, say, 8 to 10 to 12 millimeter cannula, and then expand it up to a typical lateral footprint. That would be amazing.
Yeah. I know it's a lot of room for improvement no matter what. Yeah, but the same thing, I see in my own practices is you see, there is surgeons that do a TLIF, patient go home next day, almost same day. Some of them do a TLIF and the patient stays 2-3 days in there. Same thing with laterals. I can tell my patients go home single level, like a spondy like that one, it has to go next day home. It's no reason to have it more than that. I have some partners that, it may take 3-4 days. Patients don't want to talk to anybody, horrible tight pain. It's at the end is, how you do it. And I think the ALIF is very forgivable in terms of that, It's very easy. It's a very relaxed surgery for us because most of the heat is taken by the access surgeon. You just go there.
It's somebody else's stress.
Exactly. But, I'm with you also, Peter. I like the ALIF a lot, especially 5-1 is my best go-to. But
And full disclosure, I'm a big lateral also. So like 4-5, all lateral if I can. And so to be honest, I probably would have done lateral on this patient. But if the anatomy isn't such that it works, and certainly always at 5-1, I think ALIF is the answer.
Well, excellent. We had I don't know if you guys saw this during the thing. We kind of got hacked with all the comments, and
oh my God, horrible!
It was unbelievable. And I was trying to run the slideshow and delete them as they were coming up. It was kind of hard to do both. I got most of them out, but I think it kind of scared people away from voting. So we don't really have much of a post-debate poll.
ALIF wins.
We got bombed.
We got bombed. But most people are saying anything but TLIF and ALIF all the way. So I think everybody wants to play Augusta.
That's just the access surgeons at TBI voting. That's like 120 of them.
Well, anyway, I really
my life. We just keep fighting, We just keep going.
Exactly.
One at a time.
I want to thank you guys for taking the time to share your thoughts and your experience with the world. This has been actually quite a big show, and we've had over almost 1,200 viewers watching us tonight. I'd also like to take the time to thank Integrity Implants for sponsoring this and helping get this debate off the ground. So I thank each and every one of you for all of your efforts. And with that, we're going to end our talk. So thank you very much, guys.
Thank you, everybody. This will be great.
Thanks, Paul.